Okay, all right. So I'm Sharon Kingston. I'm a associate professor at Dickinson College, and I'm the secretary of the National Prevention Science Coalition. And I'll be joined by my co-presenters, Dr. Diana Fishbein, who's a professor at Penn State University and director of the National Prevention Science Coalition, and Deborah Schaefer, who is the development officer from Hempfield Behavioral Health, which is a local agency that does a lot of prevention and programming and provides psychological services. So we're all here today through the generous funding of the Partnership for Better Health. And we're going to be talking about the impacts of caregiver substance use disorder on children, building resilience in children, and we'll be talking about how evidence-based parenting support programs, and one program in particular, the family checkup, can really be used to help children deal with some of the stress or negative experiences they may have had if they've lived with a caregiver with a substance use disorder. And the parental relationship or caregiving relationship in the family environment is really key and quite important in building resilience in all children, but particularly children who have experienced some adverse experiences. We know that people are sort of very focused in on the COVID-19 pandemic, but we also know that families are facing more stress than ever, and that families, particularly families that might be struggling or families that are in recovery from substance use disorder, really need support. And so we'd like to sort of just talk about these issues and talk about some resources that are out there to help support these families. We know very confidently, based on decades of research, that supporting children, particularly within their family relationship, and giving parents support to help children will help children become resilient and help them achieve better developmental outcomes. And there's also some good research that's also suggesting that if we really focus in on parents who are in recovery and pay attention to their role as parents and help them really fulfill that role to the extent, fill that role the way they would like to fulfill that role, and reduce some of the stress that might be coming from their jobs or their role as parents, that we're very likely to help them along in their recovery and help them maintain or achieve their sobriety. So to sort of get started, okay. We all are sort of aware of the scope of the problem. The people on the webinar, more than most people, know that despite all the attention being paid to COVID-19, we're still in the midst of an opioid epidemic. We've seen 200% increase in opioid-related deaths in the United States since the year 2000. Pennsylvania has not been spared. We know that, in fact, Pennsylvania has been harder hit than the country on average, with close to 37 overdose deaths per 1,000 people, compared to a national average of 16 deaths per 1,000. Cumberland County reported 81 overdose deaths in 2017 and 48 in 2018. Perry County reported 13 deaths in 2017 and 14 deaths in 2018. Cumberland County reported that 58 out of 1,000 newborns who received medical assistance were born affected by maternal addictive drug use. Perry County reported that close to 78 infants out of 1,000 infants receiving medical assistance were born affected by maternal addictive drug use. The largest category of reports to General Protective Services in Child Protective Services in PA in Pennsylvania are related to parent substance abuse, with 21,000 out of over 100,000 reports being related to parental substance abuse. In Cumberland County, we have 489 um, DPS reports related to parental substance abuse, and Perry County, we had 94 related cases in the year 2008. So we know the problem is still here. We know that Pennsylvania has been particularly hard hit. Cumberland, Perry, and Upper Adams County have not been spared. And so what we'd like to do today is talk about the impact that this might be having on children and some of the things that we can do to help. And so I'm going to turn over to Dr. Fishbein to talk about some of these impacts on children and the effects that this has.
So the question is, how do ACEs, how do adverse experiences have an impact on children's development to increase risk for all of these negative outcomes that are shown on this slide? Academic failure, behavioral and mental health problems, and so forth. And so what are the mechanisms? Exactly how does this work? And the reason why it's important for us to know this is because that they present opportunities for us to intervene. So what we know is that these regulatory systems that are critical to adolescent success develop before the age of 11. So it's very important that children receive the kind of skills and nurturing and so forth that they need in order for these systems to develop properly, that lead to adolescents being able to navigate their increasingly demanding environment successfully. These regulatory systems regulate our behavior, regulate emotion, they regulate the way children interact with other children and with their caregivers and with other adults. Their ability to adhere to social rules and not be impulsive and not engage in too much self-gratification, being able to delay gratification, so forth. These systems also regulate sleep and activation cycles, which we increasingly know is so important to normal development of children's brains and for their behavior and their ability to learn. And these brain regulatory systems are also responsible for the way people react to stress, not just coping psychologically with stress, but also their physiological stress responses. All of these things are necessary for adolescents to succeed as they become increasingly autonomous and are presented with new opportunities to engage in different kinds of behaviors, including risk behaviors. Can you go to the next slide, please? And just one more click. Thank you. So changes that are occurring then in brain function are really substantial during adolescence. A lot of people think that it's all done, it's all said and done by the time you get to adolescence, and that development is over and the chances for changing trajectories are past. But in fact, adolescence is one of the most dynamic periods of development across the lifespan. And what we now know from a neurobiological perspective is that adolescence doesn't end we're 18. That's a really arbitrary, legal threshold. But in fact, adolescence continues until you're almost 30 years old. And the reason for that is that the brain is being modeled throughout this period of time after childhood. And you really reach adulthood in terms of neurobiological maturity until you're almost 30. And there's two things that are happening during this period of time that are so important. And they both involve the prefrontal cortex. And you can see on this slide, the prefrontal cortex is in orange. And yes, thank you. And this area of the brain during adolescence becomes more focused, it becomes more efficient, it becomes more able to engage in executive cognitive functions, which is the cognitive control that we need to have over emotional systems in the brain, which include the limbic system. So that's the second part of what's happening in adolescence. In addition to the prefrontal cortex being more focused and more efficient, within itself, it also becomes increasingly coordinated with other parts of the brain and starts to communicate better and starts to tamp down emotional responses better during adolescence. And so you see the amygdala, for example, and hippocampus are two examples of limbic system structures that need to connect and be talked to, if you will, by the front of the brain. The anterior cingulate cortex is here as well as sort of a relay station and helps with error monitoring and things like that. So this circuit is really important and is really forming during the period of adolescence. Next, please. Now, what happens that can interfere with the development of the prefrontal cortex and with its ability to communicate with lower systems? ACEs. ACEs can interfere. And as Sharon mentioned, there are a number of different kinds of childhood experiences that can actually impact the brain. And we have measurable evidence of that ACEs affects the way children's brains function. But it's not, all is not lost, and that's why we're here today, talking about what the opportunities are that are presented by this information. And what's important here is that they're not, so there's two kinds of ACEs, if you will. There's the interpersonal, direct kind of experience that children have where they are emotionally abused, they're neglected, they may experience all kinds of child maltreatment physically and so forth. They may be witnesses to domestic violence. They may have a parent that's incarcerated, have mental illness, or relevant today, have substance abuse disorders. So these are adverse childhood experiences that are interpersonal, but they're also community environments that affect child development that are important to know. Community violence, poor housing, poorly equipped schools, discrimination, poverty, and so forth. So they can come from all sides. Next, please. And this is what we can see in the brain of children that have been maltreated. So for example, these detrimental conditions can compromise the development of the communication that I talked about just a minute ago, the communication between the prefrontal cortex and other nodes of the brain that it needs to have control of, to have emotional and behavioral self-regulation, and to control impulses, and to be mentally healthy, and to have well-being. And in the maltreated brain, you can see significantly less connectivity. So this is not a single subject. These are average groups. So these are dozens of participants that have been averaged to develop these images. So you can see the difference between children who have been maltreated and those that haven't, and the way their brains connect. Next, please. So what this means ultimately is, and this is simplistic, but we show here like two pathways. And I say simplistic, but just for illustration, what happens when you experience ACEs and your brain is affected in ways that reduces cognitive control. There's a lot of cortisol that comes out when we experience stress. Cortisol, for all of us, is released in higher amounts when we experience adversity, danger, threat, stress in our work lives, in our home lives, whatever it is. But the body, the human body, is really only capable of responding effectively with cortisol and other stress responses for about 20 minutes. For about 20 minutes, that's all we can handle. And if we continuously experience stress, and these hormones, these stress hormones, stay high and have an impact on the way the brain is developing and functioning, then we get into this upper level pathway here where, and it's subserved by the neural networks that I talked about before, where you experience danger in your environment. Your behavioral reaction is to fight, flight, go away, run away from the adversity, or freeze in place, which is usually not a good adaptive response. None of them are. And so this is what happens when you're continuously exposed to stress. And then what happens is you try to function as an adult and survive the worst conditions as best you can. So this is a negative pathway, and we call this toxic stress. When toxic stress occurs, it's continuous and it actually impacts the brain for an enduring period of time, possibly for a lifetime. And we see this manifested in children that don't respond well and adolescents that are risk-taking and so forth. But on the bottom, the better end of the continuum, if you will, is where you have a benevolent world, a world that is kind, that is safe, that is helpful, that is free from traumatic stress. And people who are on this pathway, children into adulthood, are more likely to develop a brain with cells and their wiring and their circuitry throughout the brain for being more focused, more flexible, and more relationship oriented, and they can survive well and do well and be resilient. Next, please. And what is absolutely essential for all of these connections to occur, for the brain to connect, for people to be able to exhibit the kinds of skills you need under adverse circumstances, are these core protective systems. We need to nurture these core protective systems. The capabilities bubble here refers to individual capabilities, the skills that they have, and their stress reactivity and so forth, and their sleep cycles and everything else that helps people function well, right? And underpinning that are the attachments and the belongingness that children and all people need. And scaffolding that entirely is our community structures, supportive systems in our communities, our culture, our spirituality, and so forth. So as Ann Maston, a premier stress psychologist, said, nurturing the healthy development of these protective systems, again, and I'll paraphrase, that are undergirded by these neural structures, affords the most important preparation or inoculation for overcoming potential threats and adversities in human development. Similarly, damage or destruction of these systems has dire consequences for the positive adaptive capacity of individuals. Next, please. So how do we build resilience? So what is that? In the face of adversity, resilience is the ability to remain psychologically healthy. It's not a personal trait. It's not fixed. It's not something you're born with. It's not something you just have. It's something that develops in the context of your environment, in the context of what you're exposed to. And it determines your ability to regulate emotions and problem solving. And it is absolutely contingent on the presence of supportive, stable relationships. Next, please. Resiliency involves all of these different strategies: the ability to control strong negative emotions, the ability of children to avoid negatively attributing interactions that are actually neutral or positive, thinking that they're negative, right? Not feeling trust. Framing problems in optimistic ways is resilient. Engaging in and implementing problem-solving strategies is resilient. Being able to resist impulses to be self-destructive and self-defeating, and the ability to ask other people for emotional support and help, and having those people that you can go to ask for that support and that safe haven is essential. Next, please. So building resilience is the children developing the ability to be resilient through nurturing, enduring, and stable relationships with caregivers. So it really is so dependent on caregivers in their environment. Next, please. And I love this, but nurturance, it's all about nurturance. And that's where we find that preventive interventions come into play and enable us to reverse these negative developmental trajectories. They enable us to reinforce these neural connections that support strong development and having, you know, healthy attachments and being able to be socialized, All of this is undergirded by these neural connections that allow for adaptive self-regulation. And this research supports the importance, again, continuous theme in this webinar today, of nurturing caregivers and environments. And on the negative end of it, what happens when there's ACEs, when that impacts the brain, and how can we turn it around? How can we accelerate neurodevelopment or at least normalize it when you have ACEs on board? Next, please. We know that we can exploit the brain's malleability, its plasticity, right? The brain is experience dependent. It's experience dependent for better or for worse. The worst end of the continuum is the adversity, but the best end, here is where our opportunity is to intervene and to nurture the brain. I have this picture here because these are adult brains, pre and post meditation, that where we can see actual change in the extent to which the amygdala is being stimulated while looking at emotional content. So these are the same subjects, looking at emotionally charged content, you see the amygdala is on fire. You see all this yellow. Post meditation, we see less amygdala responsivity. And that means that they are more attentive, more top-down control, more focused, more ability to cope with that stressful stimulus. And if we can change the brain in adults with psychosocial intervention, imagine what you can do with children. And in fact, we generically have found that cognitive behavioral therapy has been shown to change the adult brain between 8 and 12 weeks in measurable ways. So again, think about what we can do with children, especially if we catch them early before behavioral problems have become entrenched. Next, please. So we want to teach caregivers to teach children to do these things. What do nurturing caregivers look like? They teach children to understand their emotions. They teach them by rewarding their cognitive control over their emotional reactivity. Nurturing caregivers provide the security and the safe haven, as I said before, and instilling a sense of trust that the world out there can be safe, and nothing could be more important for healthy child development. So Sharon, I think we're back to you now.
Okay, thank you. Okay, so now, given everything that Denny has shared with us about the importance of helping children develop and the importance of caregivers in that process, really caregivers are the key in this process, I'd like to talk to you about what we like to call evidence-based positive parenting interventions. And there are a number of these interventions. They've been tested widely and extensively for the past 30 years, and we have very, very good evidence on them. And they all share some common characteristics, really, and they're all really about building a positive relationship between a parent and their children, giving parents the information and the support to be able to respond to their children in ways that are effective. And they're all delivered, they're all sort of the way that we interact with parents when we deliver these interventions is done in a very empowering and very interactive way. So sort of the baseline theoretical basis for these interventions is the idea that, as Denny has explained so beautifully, is that a positive, secure, and nurturing relationship is absolutely necessary for positive development of children with a caregiver. So these programs first, as a basis, start out focusing on building that warm and nurturing parent-child relationship. So it's about talking with parents, working with them and their children to build that trusting, positive relationship, to make sure that parents and children are having regular positive interactions that are enjoyable to both the children and the parents. If there's been any sort of disruption in this relationship, where maybe things have gone off the rails a little bit and things aren't as positive and the children aren't as attached as they should be, these interventions really focus on that, and they focus on building that relationship. After we've sort of built that relationship and we're working on that relationship, these programs generally start to look at things that parents might be doing unknowingly that's actually reinforcing some of the problematic behaviors or some of the misbehaviors, and ways that they're maybe not reinforcing some of the positive behaviors that they'd like to see. There's a great body of literature and research that shows us that when parents and children get into sort of a negative cycle, the parents or caregivers of the children actually are paying more attention to misbehavior than they are to positive behavior. And one of the things that these interventions do is try and short circuit that kind of pattern that might be going on. And what we know is that caregivers can improve child behavior and help children sort of develop in the way that we'd like them to develop by providing positive attention to positive behavior, by proactively preventing misbehavior. So you can do a lot just by thinking about the situations or the times where your child or children in generally are likely to not know how to behave or not handle a situation well. And we can proactively plan for that, learn to give clear instructions to children, learn to introduce routines or structure that can really help children or scaffold them in kind of controlling and regulating their behavior and their emotions. And we can teach parents to sort of calmly withdraw attention from misbehavior rather than reacting to it in a very emotionally charged and harsh way. And so sort of after building the attachment with children and making sure we're having positive interactions with them, these programs move into sort of helping parents develop these skills and working with parents to develop these kinds of skills. When we work with parents in these evidence-based programs, we're working with them in a way that's meant to be very empowering. So it's meant to build up their self-efficacy or their belief that they can be an effective parent and help their child. And we do it in a way that's very interactive. So there's some direct instruction on parenting strategies that have been shown to work. There's a lot of modeling where the leader of or the clinician working with a parent will model and demonstrate different strategies. Parents might rehearse and these strategies with a clinician and get coached. They'll be encouraged to try these strategies at home and then report back in their next session. And if things didn't go well, the clinician or the parent leader will help coach and figure out what may have gone wrong and how to improve things. And there's a lot of self-reflection. So parents are really, it's not that parents are told how they should parent their child or told what goals they should have for their child, but they're really encouraged to self-reflect on the type of goals they'd like to see their children achieve, the kind of positive behaviors they want to reinforce, the kind of negative behaviors they'd like to see decrease. And then we work with parents to really help them achieve the goals that they set. And again, we would really like, knowing the importance of these programs, not only for child development, but also for their likelihood to decrease relapse perhaps in parents and to encourage and support parent recovery, we'd really like to propose that referral to these types of programs becomes sort of second nature or becomes kind of a normal part of what agencies and professionals who are working with parents in recovery or parents struggling with substance use disorder, that sort of referring them to these programs is something that we think would be quite helpful for their children, to help prevent developmental issues in their children, but also to help parents be less stressed and perhaps more committed to their recovery if they link their recovery to being a good parent. And now I'd like to turn it over to Deb, who is going to tell you about a free, this is a no-cost program that's available to parents and families that have been impacted by caregiver substance use disorder. So take it away, Deb.
Thank you. So I would like to talk today about the family checkup. The family checkup is like going to the doctor for a physical for your health, only this is a checkup on your family health. The checkup can occur year to year for families if they would like to choose to do that. Family checkup has more than 30 years of evidence demonstrating strong intervention effects. Next slide. So the family checkup, it's a brief intervention with a really big impact. It helps families make important changes in how they interact with each other to prevent child and adolescent problem behaviors through,
Okay, yeah.
through strength-based intervention. It reduces child problem behaviors. It improves parenting and family management. It gives parents the tools to manage child behaviors and helps to build a positive relationship between the child and the parents. Next slide. So the power of family checkup really is in these 3 sessions that you see here. The first one is the initial interview, and the second is a comprehensive ecological child and family assessment, and that is followed by the feedback session. And we always get parent permission to schedule the first session and then the following session and then the next session to gain their buy-in. Next slide. So during the initial interview, this is the first time that the provider gets to meet with the family and the child. And this is where they really get to know them. This is the opportunity for the provider to better understand the family's concerns and needs. And this initial interview emphasizes motivational issues in parenting and child and family strengths as well. So during this part, we're not only talking about the needs that the family has, but also their strengths, and we're gaining that information directly from the parents themselves. Next slide. The next meeting that we have with the family is the child and family assessment. So during this meeting, this is when the provider collects information about each of the child's ecological contexts, including family, school, peers, and their neighborhood. Information about the child's relationships with key persons, including parents, siblings, teachers, and peers. And then information is collected from everyone using a brief questionnaire, and this is an online questionnaire, as well as a behavioral observations. And these observations generally include a brief videotaped parent and child interaction task. Next slide. You'll see here, this is just an example on the right-hand side of what the questionnaire would look like. This questionnaire can be done independently as the parent, or can be done together with the provider. And then this is an example of a stop screen of what the child-parent interaction task might look like. Next slide. So during the final session, this is the feedback session. This is when the provider shares all of the information that was collected from the first 2 sessions using empowering and clinical strategies. These strategies enhance parent motivation to set goals and engage in follow-up interventions. The provider and the parent create a shared perspective about child and family strengths, as well as challenges and problem areas. And this leads to the tailoring of specific follow-up services where parents and provider work collaboratively to create positive change. Next slide. So what does that look like? Follow-up services can include the everyday parenting curriculum. All of our providers have also been trained in this curriculum, and that can be used to work with parents on limit setting or proactive parenting, and just give them tools for their toolbox so that they can use that with their children moving forward. It could also include interventions that offer parents support around their child's school success, or services may be suggested around parent stress, substance use, limited social support, or challenges with co-parenting. Next slide. So there are many benefits that have been studied and include benefits from impact in childhood to adolescence and even into long-term impact to early adulthood. As you can see, less chance of marijuana use, less chance of tobacco use, less likely to use alcohol or to be arrested. Next slide, please. So anyone any family, birth, foster, or kinship, raising a child or children that have been impacted from caregiver drug and alcohol use can be eligible for family checkup. Referrals are accepted from Cumberland, Perry, and Upper Adams counties. The target age range for children is 2 to 17, and it can be for children that have been originated in Cumberland, Perry, or Upper Adams counties, but may have been relocated outside of those counties with a foster or kinship family. We can still accommodate them into the program as well. Next slide. And this program was provided by grant funding through the Partnership for Better Health. During our first grant year, we can accommodate 20 to 25 families, and we are open and ready for referrals. So if anybody is interested, please chat out any questions that you might have in the chat box. And if you would like to have some follow-up from this for family checkup, I'd be happy to reach out to you on a one-to-one basis and talk to you and or present to your staff about the family checkup and give you specific information on how to make a referral.
All right, thank you, Deb. And I'd just like to add that we are responsive to the COVID pandemic, so we can and do offer telehealth and sort of online-based services. So this does not have to involve in-person contact. We're more than capable of delivering this via online platforms and using a telehealth platform. Hempfield Behavioral Health is fully licensed and approved to provide telehealth, so that's not an issue. Again, thank you for listening to us.